Nizam Missaghi. I am an anesthesiologist. I work here in the Valley at various locations, inpatient and outpatient care. And it may seem a little unusual because I'm stepping outside of the bounds of my own specialty to talk about a phenomenon that is an epidemic in the Western world, in particular in the US. And it would seem that I should get one of my psychiatrist friends to be here instead of me. My journey to this field is not unusual. A difficult circumstance in my life and heartbreak and a very new way of looking at the experiences that I had personally. And of course, I reverted to my own training through medical school at the Medical College of Virginia and the things that I was told about anxiety and depression. And very quickly I realized that the remedies and the ways that one looks at anxiety and depression, one goes through medical training, are at best very limited in scope, and at worst, deliberately misleading. And so I set out to do some personal study of the latest thoughts and understandings of the topic. And I felt that I could straddle both the professional and the personal side. Because I have particularly had medical training, I have rotated through psychiatric wards, both inpatient and outpatient. I have seen the effect of this on the professional side on my colleagues, and at the same time as a person who is a non-medical person who could have been affected by all of these things. I have had experiences. And so what you will see here today, if you were to take one thing away from it, is that the concept of chemical imbalance that is told repeatedly to patients who go and seek care, that, well, there's a chemical balance in your brain and there is a magical pill that will give you this chemical kiss when you take, that will suddenly fix things for you, is very disempowering and is not the big picture at all. Although I understand that in a consumeristic society, this idea that a pill will just magically fix our problems, no matter how big they are, or no matter the extent of what they are, because you may have a problem that is a social problem, for example, or a consequence of circumstance, and we somehow seek a chemical solution to it. So the first thing is this idea that if you go to a physician with some difficulty, with some experience, especially on the mood disorder spectrum, anxiety and depression, and you're told, well, you have a chemical imbalance, realize that you need to seek more answers than that. If I tell you that, you will be so disempowered that it is all just my brain, I have no control over this, I must just commit myself to taking a medication for the rest of my life to rebalance an imbalance that is completely outside of my control. Whereas in reality, this is a band-aid solution. It's no different than telling somebody with hypercholesterolemia that, well, here is a statin drug, it's magically going to take care of your problem, and tell them nothing about what else to do to improve this cholesterol profile, from an exercise plan to a diet plan to a complete revamping of how you look at life and how your lifestyle is. That is a much harder thing. It's hard to monetize that thing, whereas I understand it's very easy to monetize a statin drug or a selective serotonin reuptake inhibitor. The difficulty that I personally went through a couple of years ago, we're among friends here, brought me to a very dark and difficult place in my life, made me suicidal for a period of time. And so my ability to emerge from it, in my opinion, had a lot to do with my self-discovery. So I want to share with you some of these thoughts because I think that it will be useful. I also hope that amongst us, I know that we already have a social worker amongst us who does also counseling, and during our question and answer session, we may be able to improve everybody's understanding. So let's just dig in and see what we have in store. So depression is rarely the result of a chemical imbalance. If anybody only tells you that, they're telling you a very limited scope of what is going on. We will talk about 9 main causes of depression. There's some overlap between them, we'll go over them. And a lot of them have to do with difficult life circumstances. Some of them we have control over, some of them we don't have control over. But our awareness of them will make a big difference in how we deal with them. Social prescriptions help people feel valued and connected, while medications do not. This is generally a problem that arises from social circumstance, and therefore social prescriptions are our first line of defense and should be the first line of defense. Non-social prescriptions may be helpful as a bridge, but they're not the whole story. This is something that we've heard of a lot. In a consumerist society, it's overly simplistic. The explanation is easy. What we sell it, we monetize it, we find a way to have people comply with it, and we can drive profits. Selective serotonin reuptake inhibitors, which are one of the most common ubiquitous drugs that are prescribed in America, are a big class that have brought a lot of revenues to the pharmaceutical industry. But the big question becomes, what's the data behind them? Are they really that useful? And we'll go over this. Serotonin imbalance story is not really a verifiable story. You cannot, through functional brain imaging, show me that somebody who is suffering from major depressive disorder has somehow a deficiency or a significant decrease in concentrations of available serotonin in their brain. But it is a story, it's a narrative that's easy to sell. Because I can come and tell you, well, I need to give you this pill, this chemical kiss that's going to increase your serotonin. Serotonin, selective serotonin reuptake inhibitors, or SSRIs, are the medicines that you may have heard of. You may not know the name of this class, but the poster child of this class would be Prozac. Sertraline is another one from that family, that's Zoloft. These are the ones that are very ubiquitously prescribed. And so when I say about serotonin imbalance, I'm talking about that particular class of families. Irving Kirsch is a Harvard professor who questioned the efficacy of antidepressants and found many were not better than placebo, with selected small studies only submitted to the FDA for their approval. When you want to go through the FDA, we all know FDA is pretty rigorous in getting a medication to be approved. It has to be superior to placebo. The pharmaceutical industry that put a lot of resources into developing these drugs was very selective in which studies, and however small they were, they submitted to the FDA for approval. If they had submitted every single data point that they've gotten, they would not be able to demonstrate an efficacy of these medications over placebo. And realize I'm talking about their utilization for mood disorders only. There's other utilizations that could be happening. There could also be utilizations of these medications happening in particular with suicidal patients. But I am very specifically talking about chronic maintenance of this. At the same time, I'll also tell you, if you happen to be on one of these medicines from these families, you are not going to, based on my conversation today, come off of these medications. You will have to do it in collaboration with your physician who is treating you. But I am telling you, you should question when somebody gives you a prescription as to what the efficacy of this medication is. What percentage of people improve what percentage of the time? And this is very important how we deal with these questions. So here, sometimes we have, haha, look how I misspelled symptom. So in the second one, you have a problem that's usually a symptom. If you go to a physician with a fever, they will tell you, well, your fever is a symptom of another problem, correct? They won't say, well, you just happen to suffer from chronic feverosis. That's not a medical term. If you have hematuria, which is blood in the urine, they don't come and say, well, you just have blood in your urine. It's, you know, it's the case, we're just going to give you a transfusion every now and then. That is not going to happen. These are symptoms. You have chest pain, they won't just say, well, your chest hurts, so big deal, here's a pain medicine, which will take care of your chest pain. They will look for an etiology or a cause for this chest pain. But if you go and say, I have depression, they're like, well, you have a chemical imbalance, you're just depressed. That is a problem. Depression has to be seen as a symptom of another ailment or difficulty. So you cannot suddenly say, well, this is itself the primary cause. There are circumstances where depression could itself be primarily due to a chemical imbalance, just few and far in between. Let's talk a little bit about evolution of humans, because this is at the crux of the discussion today. Over tens of thousands of years, the modern human has lived in a very particular kind of way. The humans that survived, that were our ancestors, our collective ancestors, they were hunters and gatherers. By definition, the ones that survived were more social people. How do we know that? Because we know that the ones who were loners were not able to collaborate with others as much, and by natural selection, they just didn't quite make it like the rest of them, who were more able to collaborate and engage with other fellow humans. That we know. We also know that they spent a lot of time in nature. They touched the dirt. They touched the animals. After the agricultural revolution, they cultivated the earth. Agricultural revolution, if you recall, 10 to 12,000 years ago, depending on what part of the earth we're talking about. So they were in touch with nature, they were in touch with the earth. They breathed the air, the smells, the visuals. They spent a lot of time in nature. They collaborated together, they socialized together. They found meaning in all the activities they did together. They shared stories together, and they wrote these stories as inscriptions, the results of which are still available in caves and things that we can go see. They were also very physically active, because to be a hunter and gatherer and survive, you had to be very agile, and you had to be able to collaborate, and you had to be out there. If you were a couch potato, you didn't make it as the prehistoric man, right? You just had to be out there. And this is the animal that we are as human beings. This is how we were selected for over tens of thousands of years. We know also that when we take an animal out of nature and put them in a zoo, in a confined space, they start manifesting illnesses that they've never been seen in nature before. They start having a shortened lifespan. Now, how do you think it would happen where you take a particular animal that we are, out of our usual milieu in which we have grown and evolved over tens of thousands of years, and put us in the cubicles and in an urban life, away from nature, away from meaningful human interactions, and expect that we should just get along fine? Now, why didn't our longevity go down? Well, because we are smart. We've come up with various different kinds of medicines and clean water and vaccinations and all these things that have helped us keep our longevity going. But the space in which we live is nothing close to the natural space in which we were meant to thrive. The big common theme that I'm going to talk about today is connections. Connections has to do with a sense of belonging. We have to find where these connections are. When I talked about the evolution of man, if you noticed, everything that I said had to do with connections. You were connected with the earth, you were connected with the landscape, with other people, with physical activity, with shared stories, with your future. So all of these are going to now come and play into what we're talking about. So we have a problem of disconnection from others, especially in Western societies. There's no sense of belonging, or very diminished sense of belonging. And there's an epidemic of loneliness. Please don't confuse loneliness with being alone. There are people around whom there are many people. You could live in a home of multiple people in a large family and still feel very lonely. You may only have one or two friends and not feel lonely. This is not a quantitative assessment. This is a qualitative assessment. So what is the quality of the interactions that you have? That is at the crux of our discussion. The second is disconnection from meaningful work. What does that mean? Well, those with least control and authority in the workplace are at higher risk for depression and helplessness. We seek meaning and purpose. This is part of human nature. We want to find meaning in things that we do. As a matter of fact, you guys have heard of this idea of life, liberty, and pursuit of happiness, of course. This is an American axiom. Pursuit of happiness itself is very elusive. And I often like to say, we seek pursuit of meaning. And a byproduct of pursuit of meaning is happiness. Because happiness itself is elusive. You just try to be happy. How much happy and by what circumstance is always hard to define. But if you ever engage in an activity that brings you meaning, I assure you that as a byproduct of that, you will find happiness. So I always say pursuit of meaning, but I understand pursuit of happiness is how it's framed, and I get that. But to give you an idea, there's a lot of research behind the things that I say, and they may be beyond the scope of today, but at least as in the form of a highlight, I want to tell you, people have looked at employees that are in different work environments. They have separated groups of people, they've studied separately the groups of people. One of them, imagine, live and work in a particular circumstance where they're employed, they're given certain hours a week, they don't have much control over their schedule, and they have to come and do this repetitive menial task of whatever it is. Imagine as kind of the poster child of that a Walmart employee. There is no really meaningful connection that that employee may have in the type of work the employee does. A lot of it is dictated to them with little control at all. Now contrast that with somebody whose work includes being a part of a cooperative. A particular company that is run in a way that everybody, regardless of what function they have within the organization, is given some shares and is given some say in how this company is run, to different degrees. And if you were to compare these people, the people who work in cooperatives will always report more meaning. Connection to meaningful work is one of the immunizations we have against depression and anxiety. We also have disconnection from meaningful values. Consumerist societies value competitive behavior. Our worth is defined by our possessions in this kind of environment. Display of virtues takes a back seat. Happiness index improves in societies that de-emphasize consumerism. So here you may think that you came to talk about psychology and psychiatric concepts, and you are promoting a political agenda. I am not here to give you a political agenda, but I am here to tell you that given that there are different countries that run their affairs differently, and we have metrics to look at human happiness, we have metrics to see how people behave and how much they consume psychiatric type medications, we can have a lot of meaningful data about these things. And so one of them is that in societies like the one in which we live, we are at a higher risk for these kinds of mood disorders because meaningful values are de-emphasized. The values that are emphasized are not the kinds that have as much meaning. They have a lot of meaning to GDPs and metrics having to do with the economy, but they may not have a lot of meaning in human development sense. And so there is a balance somewhere. We know that Nordic countries beat us by a far margin in their happiness index that are looked at, but at least our awareness of the systems and how we interact with them and how they affect us are important. This is a big one. Childhood trauma, child abuse, household dysfunction are strongly correlated with anxiety and depression. Additional multiple health risks, such as substance abuse, smoking, heart disease, venereal disease, even obesity, exist. So childhood trauma isn't just, well, you've had some childhood trauma and now today you're going to have depression. You may actually have high blood pressure as a result of it. You may develop obesity, you may develop diabetes, you may develop sleep apnea. That is not to say everybody with sleep apnea has had childhood trauma, but the people who've had certain traumas, certain neglects, will have both psychiatric and physical manifestations of that trauma. What's also interesting about childhood trauma is that there are a lot of people with childhood trauma who are not aware that they've had childhood trauma because there may have been a lot of repression, there may have been a lot of overlooking these things and processing it as not trauma. So going through a process where in a safe space one can discover these things may actually be helpful in understanding one's risk factors. Disconnection from social status. So countries with the largest gaps in wealth and poverty report the highest rate of anxiety and depression. The US, of course, is the highest consumer of antidepressants amongst the developed countries. And so here we have, it really goes back to the work situation that I earlier talked about, but social status is important. And so because there's a lot of judgment that goes to that, and people who live in societies in particular that don't have a lot of social mobility, vertical social mobility, are at higher risk of being higher consumers of the antidepressants. Since we already talked a little bit about this through an overlap with another, I'm going to skip to the next one. This is a big one, and this is one that's frequently overlooked. We know that there are studies looking at people who live in urban environments and people who live in the countryside and in farms, for example. And there's a difference as far as how they report anxiety and depression. They have less depression and anxiety if you live in rural areas. Within urban areas, the numbers get more, but even within them, the ones who live in places with more green spaces around them will actually report less depression and anxiety. And people who make a deliberate effort to connect with nature at frequent intervals are less likely to be depressed. There was one study that says there are measurable chemicals that your body releases every time you are in nature. These are feel-good hormones, if you will. And they will last for days every time you go. So it's like if you want to protect yourself against these kinds of mood difficulties, every time you go, I assure you that the next several days after, you are going to reap the benefits of that visit to the nature. And it's very important. So when a friend of yours says, hey, you want to go hiking this weekend, and it's just cumbersome to wake up at 7 a.m. or 6 a.m. on a Saturday morning, you should probably reconsider that. Because all week you've been in your cubicles. All week you've been indoors. And if you get a chance to connect and reconnect with nature, magical things will happen within your body. Do not underestimate the effect of this. Disconnection from the future is also important. Lack of hope would be another way of putting this heading. Anxiety and depression can be symptoms of fear and lack of security. Native Americans make a great example. As you know, some of them are in places where there are government-controlled reservations, and some of them live in places where they have somewhat autonomous circumstance over the land in which they live. And if you compare these two populations, their rates of anxiety and depression are very different. This is just one such example, but you have to have some control over your destiny. If you don't, you will find yourself in this dark space, and it's just not a natural thing to be. The old human that we talked about, they had some understanding of their future. They did not feel burdened by debt or by creditors or by collection agencies or whatever we have in this day and age. So disconnection from the future, from meaningful future, is very important. Suicide rate also works into this. Any illness, any disorder can lead to complications. The most dreaded complication of depression is suicide. In the same way that diabetes can kill, depression can kill too. And so with a lot of these conversations that we're having, we're looking at saving human life. Not only we're looking at saving human life, but we also want to improve the quality of life for those who have it. Next, we're going to talk about genes. There are some people who genuinely are predisposed. So some genes have been identified that explain why depression runs more frequently in some families compared to others. Yet these only explain about a third of the reasons why one may receive the diagnosis of major depressive disorder. They generally combine with environmental factors. Adoption studies shed light. So there are situations where you would have twins, for example, who are genetically identical, but they are separated at birth and raised by two different families. And you will see one of them, whose mother may have been depressed, for example, will show depression, one of them will not. How are these things possible? Circumstance, life circumstance will still steer you in whether you're going to manifest this or not. When I said it runs in the family, there was a funny medical meme I saw once that this obese patient is sitting with the doctor, and the doctor says, "Does obesity run in your family?" And he says, "Nobody runs in my family." And so, but yes, depression can run in families, but you have to be mindful that environmental circumstances will either help you manifest it or not. And so it really is not as significant as you would think. Let's talk a little bit about changes in the brain. So this has some overlap with abuse that I talked about. Neuroplasticity, this is a big term, but it basically means that our experiences can help shape how our brains work or how the circuitry of our brain can alter. Chronic experiences, thoughts of despair will strengthen and shape and reshape the corresponding areas of the brain. So it becomes something, a self-fulfilling prophecy, it feeds into itself, creates a vicious cycle or a positive feedback loop. Childhood trauma, we talked about this, but so is adult trauma. PTSD is a big thing, especially when you're talking with the Veterans Administration data, you will come across this. There are people whose brains and the way the brain functions in response to certain stimuli can be permanently altered on the basis of certain experiences that we've had. PTSD falls in the mood disorder spectrum because it is one of the anxiety disorders. And so seeking help is paramount to break this cycle, because this is not, once the brain is altered, it doesn't mean that you can no longer go back on it, but the awareness that your brain can get altered and it can become hypervigilant, like a stimulus that's usually not very significantly evoking of a response may evoke a very severe response in people like that. That's the definition of hypervigilance. And so that is a manifestation of a changed brain. And so how can we prevent this? We can't prevent it, but we can receive care if we understand that we have gone through certain difficulties that may have changed how our brains function. And there is more role with some medications in this arena. As I said earlier in the talk, chemical prescriptions are easy, are profitable, and they just kind of work and they help you get the patient out of your office after an 8-minute visit. Social prescriptions are harder. They require a particular commitment to a change, both by on behalf of the patient and on behalf of a therapist who decides to make a long-term commitment to the transformation of this patient. But bottom line is that social prescriptions are far more effective than their counterparts. So how do we do this? We talked about all of these things have to do with connections. So we need to reconnect with people around us, focus on meaningful work, sharing of meaningful values, receiving therapy for facing traumas. And there are some examples. So for example, this depressed RN actually is a real life example of a nurse who was receiving some bullying, some difficulties at work, and she really felt very helpless based on her work, didn't feel like her work was very meaningful, didn't feel that she was in a good place in life, and she lived in the UK. And she got enrolled into a study where a group of people under some supervision who all had some difficulty along the mood disorder spectrum were put together and were given a meaningful task. And the task was that in a particular neighborhood in London, there was a plot of land, a significant plot of land that needed to be beautified and a garden needed to be made there. They gave them a purpose. So these people all came together with frequent meetings to try to study, based on the weather conditions of London, what kind of plants, for example, would grow very well in that area, that perhaps how they could collaborate and how they could bring irrigation to it, how often which each of them would go visit to make sure that the plants are growing well. This was a year-long study. And at the end of the year, many of these patients had come off of their antidepressants. It's a remarkable study because it has a lot of the elements that we talked about the prehistoric man having had, such as the prehistoric man was connected to nature. We need to touch dirt. There are, and this is not just some new age, I'm just sitting here because it's all kumbaya, let's hug and touch the earth. I am telling you because there are so many things in the earth, so many good microorganisms that will end up under our nail bed, that may end up helping redefine our GI tract, because the brain and the gut are very much connected and in harmony. And through all of this process, and the fact that we know those who work in rural areas tend to have far less of this depression problem, we know that there is remedies in such micronutrients that may come to our body through touch. And so they got to touch the earth, they got to cultivate the earth, they got to collaborate with other humans who may have had similar experiences. They got to study, they got to have a purpose. They had a connection to a future where this plot of land would beautify an entire neighborhood. So if you start looking at these patterns, you will see. And it's not for me to go tell somebody, well, you're feeling a little down, why don't you go plant some plants in your backyard? This was done in a very supervised circumstance, but it's also a testament to how critical it is for us to have a sense of connection to each other. We're going to talk a couple of things about medical prescription. So, medical prescriptions, especially the selective serotonin reuptake inhibitors, tend to have more efficacy in certain circumstances, such as getting somebody who is suicidal off the ledge, for example. And that under significant supervision, because sometimes when you start somebody on them, at first their suicidal ideation may actually increase rather than decrease, so you have to be very careful about how you utilize them. But one thing that's for clear is that you're guaranteed to have side effects, but you may not be guaranteed to have relief. And if you have an initial relief, it may be that because your brain wants to get better so much, it's a placebo effect, it really wants to get better so much, you will start taking it, you feel better, but soon enough, within a few months, a lot of those little dark thoughts will start seeping through. You go to your doctor, and naturally the doctor says, well, you might just not be on the correct dose. And they will just up the dose. And the more you up the dose, the more the side effects increase without really a meaningful efficacy added to what you're receiving. And so what are some of these difficulties that patients have with these particular medicines? The simplest ones are sweating, weight gain, which is a very significant thing because weight gain is a multifactorial problem as far as the health of the patient that in itself may actually lead to more anxiety and depression because there's social isolation that comes with obesity. Completely goes against this whole idea of connecting. Sexual dysfunction is a big one, it's very common with these particular medications. Just the isolation that we talked about. So these are not benign medications. The efficacy is questionable in the long term. There is also a need for increased surveillance, especially if young patients are placed on these medications as teenagers, that they may suddenly go off the ledge with suicide just as these medicines are coming on and changing the balance of neurotransmitters with their brains. So they're best used as bridge rather than anything else. Teaching old dogs new tricks, well, thinking outside the box with prescriptions, since we're talking about medications, are very important. So adding non-antidepressants to the mix would be useful. There are medications that may not necessarily have been approved for depression, but can help people's moods stabilize, for example. Some of them may be from the anticonvulsant family, for example, or some of them may be old medications from the tricyclic antidepressants that may have some efficacy compared to the selective serotonin reuptake inhibitors or other ones that modulate neurotransmitters like Effexor, things that you frequently hear about. Combining medications with cognitive behavioral therapy is very important. There are various kinds of therapy. The most studied of all kinds of therapy is cognitive behavioral therapy. It is very rigorous, it is very structured, it does require a commitment to frequent visits with a therapist, but this combination is useful. Now, mushrooms and ketamine. There is an increased interest now in the psychedelic research. It used to be that psychedelics were all bad. They were all Schedule II substances and nobody had to touch them and nobody had to come around them. But now the FDA has reopened them, especially in research format, and has realized that people who are in the depths of difficult clinical depression may benefit from these things. That if you bring them to a controlled setting, you may help them in resetting. In the same way that when your phone kind of acts out, you're like, wow, I'm just tired of this darn thing, and you reboot it and suddenly, magically, things get a little bit better. You can reboot the brain through exposure to some psychedelics. Ketamine is a hallucinogenic drug. It works through the NMDA receptors. It's not an opioid, but in low doses has been shown to reverse suicidal ideation in patients who show up on the brink of wanting to take their own life, and within 24 hours have been completely reversed by exposure through ketamine. Ketamine also has anti-pain properties. We know that pain management and the opioid epidemic is a big problem in America today. But we also know that chronic pain and depression are sisters. I should say brothers. That sounds so sexist when I say they're sisters. They are brothers, and they're very much related, because if you're depressed, your body is going to perceive your pain differently. And if you have chronic pain and not depression, you're just going to get sick and tired of the chronic pain, and the depression will follow. So whichever one you start with, the other one is going to be right around the corner. And so ketamine has also been used in helping break the cycle of pain through a non-opioid approach. psilocybin, the active ingredient of these magic mushrooms, has been shown in helping people break some habits that seem unbreakable. Somebody who's been smoking for 40 years sometimes goes through this and has 80%, for example, in some studies, chances of kicking the habit after one treatment. Very significant. Certainly more than double what it is with nicotine. But also have been used in major depressive disorders with psychosis, with elements of psychosis, in reversing these kinds of things. So I'm not an anti-drug person. Obviously, the funner the drugs, the more I am going to talk about them. But I am here to tell you that we have to think outside the box. These are a lot of old drugs, and they're coming around. And when I talked about non-antidepressants, sometimes a dose of stimulants have also been used in helping elevate mood, especially in people with chronic illnesses and terminal illnesses, and with some degree of success. And of course, for the most severe cases, a jolt of electricity, or what's known as electroconvulsive therapy, has been used. There has been a resurgence of interest in this topic as well, but it comes with its own difficulties, such as short-term amnesia and those kinds of things that are beyond this topic of conversation. This slide. So some of my final thoughts as far as putting these things together. Depression is a symptom. It's not a primary disease. It's a symptom, therefore it should be treated as such. The roots of it, such as whatever connections we have lost along the way, ourselves or generationally, have to be looked at. What is a symptom of? Lack of connection and loneliness. Loneliness is another epidemic we have in America today. Depression is mainly a social phenomenon and not a chemical phenomenon. Therefore, chemical solutions should not be first line in therapy. Depression must be destigmatized. 1 in 5 Americans report being low on their luck or having depression or some elements of it. You have to understand that DSM-5, which is the main manual that all psychiatrists and psychologists go by so that they can standardize how they talk of things. And a lot of things in there are put together by convention so that everybody agrees how and what they're talking about. It's a very big manual. Diagnostic and Statistical Manual is the name of it, DSM-5. It allows for defining all psychiatric disorders. But generally, in order for something to be defined as a disorder, it has to impede with your day-to-day function. We have a lot of people who are just kind of down every now and then. That doesn't mean that they have clinical depression or major depressive disorder. There are criteria that one has to meet before you can call somebody as having MDD or major depressive disorder. But I'm talking about there are a lot of preludes to one getting to major depressive disorder that can be manifested in all of our lives. These lack of connections, these difficulties, these dark thoughts that may come to us and go as fleeting thoughts, they are important. We are not to ignore them. And so if we don't do that, and if we destigmatize the idea and not call it a mental illness, but call it our reaction to our circumstance, then we're more likely to receive care sooner. And before these things gather so much momentum that they impede with function, we can actually prevent it. And this is about the dose of prevention that's better than a pound of cure. So early recognition and treatment is very important because the brain changes can be permanent and can come later. So don't ignore the warning signs as you feel them. Go seek therapy, don't feel the stigma. And of course then adopting a lifestyle of connection is the best immunization for our children and ourselves as well against depression. Find a way to have common meaning, common goals, common activities. That is why there are people who really have a very significant sense of belonging, say, to the faith community with which they stand identified. Or there are people who take their tennis or squash very seriously. or they take their music and culture very seriously, or the band playing very seriously. All of these things, and it would seem kind of an annoyance. You're like, well, please come over. They're like, well, our band is playing. It seems like, well, why wouldn't you come do this? But you have to realize that falling into these regular habits of connecting with other people with similar beliefs and similar ideas and similar enjoyment are all immunizations for us against having that major depressive disorder down the line. And I think that I'm done with this, so I am happy to entertain some questions or anybody who wants to share any story that you think will add color to our conversation. I'm more than happy to entertain it.
I went to the doctor after my husband died, and the doctor ordered some antidepressant pills. And depression and grieving are two different things, and I want you to speak to that.
Mm-hmm.
Could you speak to that?
I could speak to that. So if you look in DSM-5, the major Bible of how psychiatrists and psychologists communicate, there is a grief exception when you are to define depression. Grief is, in my opinion, love that does not have a target to go to. Grief and love, in my opinion, are one and the same. When your love cannot find its object, when that object is lost, the love that is contained within you and cannot be expressed becomes grief. It is true that depression and grief, as far as helplessness and feelings of being down or in a dark place, have a lot in common. But generally speaking, practitioners of psychology and psychiatry are warned to allow for the grief exception, because it is part of the healing and the closure that one has to go through in the process of dealing with a loss that is a very significant loss. And so to very quickly go to someone who has had a very recent loss, there's a period of time that has to lapse before they're allowed to then call it depression. And I don't remember off the top of my head how long that period is. To so very quickly say, well, you're just depressed and here's a pill, I think is a quick fix kind of an approach that probably doesn't really work very well. I think that there is a lot of healing that could happen through finding a listening ear and someone who is willing to be with you and coach you through this process of grief that will go far beyond any chemical can ever do to your brain or to your well-being. And so I think that your physician, I don't know how long after your loss you were prescribed, but generally speaking, the grief exception in diagnosis of depression exists in the DSM-5 and for good reason. Okay, you go ahead first and then you can go.
In my opinion, immigration for the people is a big dilemma, especially for the adults, and it makes depression for a while or a long time, it depends.
Yeah, so immigration, so any major life change.
Yeah, because
immigration and grief have some overlap here, right? A major life change where one has to learn a new language and a new culture and a new job and new connections, all of these things, because remember, at the crux of our conversation was connections. So if you are disconnecting yourself deliberately from a previous life, and now find yourself to try to reconnect in a new place, you are no different than a sapling that was uprooted from one place, and now we are watering it, giving it resource, and trying to see if it will find new roots or if it's not going to survive. And in the process of finding its roots, it's going to look very weakling and very ill and very difficult. And so I think that is the plant equivalent for depression, and it's very well placed, probably bordering on grief more than anything else over all of what is lost. Please.
I wondered if anxiety is somewhere on the continuum of depression. In other words, if you're have the disconnection you talk about, can that bring on panic attacks?
Absolutely.
Is PTSD more anxiety or depression?
Absolutely. The two of them are very much interrelated. They fall, if you look in the DSM, the big Bible of psychiatry, anxiety and depression fall on the same spectrum of mood disorders. And so they're not considered really separate. It's possible that some people will experience what they're experiencing with more the anxiety side. And the anxiety side is when there are physiological manifestations of one's fears and worries. What do I mean by physiological manifestations? Where they would have a measurable change in certain stress hormones that will rise in their body, where their heart rate will go up, where they will get cold and clammy, where they will get the fight or flight reaction, a big sympathetic discharge in their body. And so PTSD and panic attack are very much related. PTSD is just a more chronic sort of hypervigilance that looks like panic attacks as well. And so, and they are all very much interrelated with depression. I think at the base of a lot of them is a sense of helplessness and a sense of fear and a sense of lack of security. And so all of those things, hand in hand, work together. And if you were to try to, A, through cognitive behavioral therapy, and B, through finding new connections, reestablishing whatever can be done. It's hard to go to perhaps a Walmart employee and say, you must find meaningful work. This is easier said than done. But if they were to find other things that will bring them certain satisfaction and meaning, it will be helpful. In the same way, people with PTSD are going to have to find activities that bring them new meaning. And so through that process of discovery, that can I don't know who else had a hand up. Okay, let's, you go ahead first, ma'am, and then, or, okay, you go ahead first then.
Okay, I have several questions. One is related to our friend's opinion about immigration. I think probably, I don't know, immigration cause stress, and stress cause secretion of some hormones like cortisol. And cortisol effects on, nerve system, and it causes some, secretion of neurotransmitters, and it makes such problem that we face to it, depression and anxiety. Because there is a triangular shape connection between immune system, endocrine system, hormones, and the other one is brain. So all these three affect each other. But my question is, which one is most important and can be, most effective factor for depression?
If I were to say which one, I would hang my hat on the connection side. That one who has connections to nature, to their community, to meaningful future. Because immigration has to do with a willful act in which you want to connect to a different future, but that future is still elusive. And so I think that still seeking connections would probably be the most important of all, but I'm glad that you mentioned, if you notice, she mentioned a lot of different bodily functions and systems. And the truth of the matter is that today's medicine is very compartmentalized. You have an endocrine problem, you go to the endocrinologist, and you have a neurological problem, you go to the neurologist, and I understand these people are very highly specialized in what they do. But the idea is that all of these systems are very much interrelated. That you could have PTSD, as the gentleman mentioned, and it will have physical manifestations. You could have an issue, a problem within your GI tract, and you will have very difficult neurological problems. And nobody would ever think that the brain and the gut, for example, have such a close relationship. And so they are all so interconnected that it's hard to parse which one is so much more important. But as far as regaining our mental health or reclaiming it, I think our focus has to be on what are the connections that I'm losing and which ones are most easily reestablished.
And
Go ahead.
ask the other one. And the other part is nutrition, which include trace elements and vitamins. Like vitamin D deficiency is one of the factors can cause depression. In the areas that there is no sunshine and I don't know, like polar parts of the world, the depression is much more than the other areas of the world. I read about it. And
Certainly
it's
possible. So
probably because of vitamin D deficiency.
vitamin D is important. Vitamin B12 has
12,
also a lot of
yeah.
neurological manifestations that could happen. Folate has a lot of neurological manifestations where there's a deficiency of it. So I think that it's certainly warranted that somebody who goes into the position have some basic laboratories to make sure that these elements, the trace elements that you're talking about, are finding a reasonable balance. Some of them, unfortunately, aren't really established. Like, how much zinc is good enough zinc, I don't know, and I think it's hard to establish those things. Nonetheless, point very well taken, that we have to eliminate all the environmental factors while trying to behaviorally and socially find solutions as well. You had a question?
I just wanted to say thank you for mentioning connections to all of those different levels, because as we see with our young people in society with a high rate of suicide, I'm realizing now that the more connected they are to their devices and the less connected they are to other human beings and people that care about them and people that love them, it's causing these levels of depression and anxiety in young people and children with lower and lower ages, more so than ever before.
That's a very good observation, and I could not agree with you more. We are in the midst of an unprecedented and unwitting social study that has never been performed before. That there's an entire generation that is completely disconnected from meaningful interaction with other fellow human beings. Over tens of thousands of years, we developed and we thrived through these connections, and now suddenly, within just a generation and discovery of this magical touchscreen, pocket-fitting device, we have found ourselves ever so more disconnected from each other. And so to have rules within the household with these young folks where this is like a device-free zone or this is a device-free time where people are actually forced to tell stories to each other, because that's one of our strongest magical powers as human beings, is storytelling. And so if we can reestablish those things and be able to get to reinstate the art of storytelling, I think we will be far ahead than we could ever be. Connie.
I have a question. With the experience that I have with a family member, we have a hard time finding someone who looks at the approach to helping this person in that kind of a light, the kind of light that you just discussed. We've been looking and searching, and you just get this big list of doctors, and you don't know who is good or who is going to, be the best for this person, and then they just seem to just give medications, and then if it doesn't work, they go to another medication. They higher the dose, they add another medication to it, and it's just hard for me to find someone who is a professional who can give similar advice or not just jump to a medication after medication after medication.
Yeah, there is a lot of trial and error that occurs in psychiatry. They're like, well, we tickled your norepinephrine, let's go after serotonin, well, let's throw an anticonvulsant at this. I mean, there's a lot of trial and error. Keyshawn is very well aware of this, we've talked about this. And so it's very unfortunate. It may even not be one provider who's going to be the one who helps. the particular person you're talking about may need to find communities that collaborate together with common goals and connection to each other and to a meaningful work that they do. All of those things as supplement to the medication track may actually help and modify and change the doses of the medication side. But as long as you're pushing the medicine, sometimes we just make zombies of our patients who become far less functional and have weight gain issues and now are even more socially isolated. And so I think that it's not really an individual, but it's collaborative environments where other people with similar difficulties are going through. Not only talking about group therapy, which can have efficacy, but I'm talking about people who have common goals of finding things to do. Where do you find them? I can try to look for some resources for you, but I know that these kinds of approaches to mood disorders are actually not necessarily the norm, so harder to find.
So I'm a master's level social worker. I'm finishing my degree in May, and I'm trained in CBT. I use the DSM-5 all the time. I have clients who present with depression symptoms, PTSD. This is my field. In terms of this approach, it depends where you go, right? So like a psychiatrist, their training is very much in psycho-ed and in medication, right? Like a psychiatrist dispenses medication, but a psychologist is more going to use CBT, maybe EMDR, talk therapy, narrative therapy. These are more centered around not using medication. Social workers who are master's level social workers, finding a licensed clinician, so an LMSW, licensed master social worker, or an LCSW in their own private practice. Social workers were trained to look at human beings in a person and environment setting. So we're actually, this is in our training, this is to look at a person in, what are the systems that they're engaged in? So like their environment, their social connections, their like the macro level, what policies are going on, what different things. So our training is actually in line with this. Our training is in, social workers aren't, we're not given the training to give medication. Where we can diagnose and we can treat, but we don't give meds. So, I mean, if you're looking for a mental health route that's a little bit more on this tip, then I would suggest a social worker looking for an LCSW.
We have the last question. I read that just 70% of the patients are responsive to the treatment. How about the rest of the patients, which is 30%? They are not responsive to the treatment, and how can we deal with this group of people?
I am not familiar with that statistic. It all depends on how we define responsiveness to therapy. For example, it's nice to have some metrics. For example, if somebody who is unable to function or go to work or hold a steady job is able to be rehabilitated to go back to work, for example, is that success? That would be a good, hard evidence of success. But if someone says that I was suicidal last month, now I am not, but they're still unable to function, is that success, is that not? It's very hard to define what actual success in therapy is, depending on how we define our goals. Nonetheless, I think that we have generally an access to healthcare problem, especially people, because access to healthcare in America generally is connected to employment, and a lot of people with difficulty with mental health are not able to be employed, and some of them may have means beyond what would get them qualified for the government-based assistance, and so they find in this kind of a no man's land. So the first thing is access to care, and the second thing is really access to someone who's willing to spend time and find these root causes of lack of connections with people, rather than telling them, oh, you feel down, here's a pill, go see you later, because they have another 50 patients to see the rest of today, and they're only going to give them 4 or 5 minutes. I think that majority of people will have some improvement if they're given the right kind of attention and care. So while I don't know the exact percentages, I think improving access to care through legislation or through whatever mechanism that we have, and also finding the right therapists who are willing to spend time would probably be the right approach. The gentleman in front of you had a question.
Could
Then
you-
after that, I'll take another question, and I think for everybody's benefit, probably, well, please go ahead.
Could you explain the connection between depression and grumpiness?
So, you know, I like the question. I appreciate the humor embedded in the question. I would say that there could be grumpy people who are not depressed. And there could also be depressed people who are not grumpy. So I don't think that they are necessarily ones that go hand in hand. I'll give you an example. This is a difficult example, but Robin Williams was not a grumpy man. But he suffered from the most significant depths of depression that essentially took his life. And at the same time, you have those who may just have a facet of their personality as grumpy, but if you were to ask them specifically, are you sad? Are you feeling disconnected from your community? Are you lonely? They may just, in a very grumpy self kind of way, say, no, not at all, I feel just fine. And so I think it's very hard to associate the two together. Depression is really kind of like pain. It's what the patient tells you it is. It's not, we can't really go to someone and say, well, I think you have depression. I think it's best to ask them, tell me about how your mood has been, with an open-ended question, and have them present to you how their feelings are. I know grumpiness is usually what we perceive in the other person. They may themselves not perceive how they are that way. And so usually the way to explore it is self-described and not externally observed. Nadia.
Yes. So I just wanted to add a comment. I think it was really interesting that in the presentation, the stigma of depression and therapy was mentioned. So I think like within our culture, it would be wonderful to kind of start transforming our mindset when someone says, I'm going to seek therapy. I'm seeing a psychologist. This is how my therapy session went. Just being very open of having these conversations with each other, because I think even for me, like there have been times where I've had to seek a therapist for help, and it was really inspiring when my older, when the adults in the family also said, you know what, I get therapy too. That's totally normal. That's totally okay. I've also, on the other part of the spectrum, seen that people are like, oh, you're still getting therapy? Oh, move on, like seriously? Like that thing happened a couple years ago, just jump up from it. But it's like, no, just being really sensitive and being open to having these conversations with each other. Oh, you're seeing therapy? Good for you. Because I think mental health and physical health should go one-on-one. Like if you're seeing your PCP once a year at least, and you're doing well, you just want to get your, blood work done and just, it's routine maintenance, I think mental health should be elevated to the status of physical health because they go hand in hand, as was mentioned. And also the second comment that I had was finding the right therapist makes all the difference, really, for you, because, just seeing that who is the person that you vibe with, that you can sit down for an hour and say, these are my problems. Help me, and just being very open about your problems and finding that person and that modality that works for you. So.
Absolutely.
Well, I'm talking about what she's talking about. I mean, insurance runs the world. So, if your insurance doesn't cover that particular type of therapy, the out-of-pocket cost is extreme. So, I mean, I totally agree with what she's saying about the physical part of it, but when it comes to mental, you're at the mercy of whether or not you can see that person. Or I found just repeatedly, your insurance might give you a list of people to call. Those people might never call you back, or they're not taking new patients, and you might not ever get an answer. And for somebody who's medically fragile, who's calling the insurance. That's like the worst case scenario for somebody that's already depressed, to have, no one return the call or have them not taking your patient. So it's vital that somebody help that huge gap in there.
You're absolutely right, and I think at the crux of what you said is, at some point as a nation, we may have to revisit this question of whether access to healthcare is a right. And because of all this heartbreak that is unfortunately occurring, I don't want to venture into political conversation, but it is virtually impossible to talk about mental health issues and not consider the political forces that control such matters. And so you're absolutely correct. And it should be a right. It should be, in my opinion, accessible for anybody who needs it. It improves the overall health of society. It's not just the person, because the person lives within that society element that they are. And I understand these are easier said than done or implemented, but those are the kind of getting to the crux of the matter ourselves as to who we want to be as a nation, I think are very important. And to your point, before I take the final question, to your point, I think it's very important to be able to talk about it. In the same way that telling somebody you have a chemical imbalance is very disempowering to them, I think it's very empowering to say that you have received therapy because it means that you care for your own well-being, psychological well-being, in the same way that you may say, I have received care for my diabetes or for my high blood pressure. And so I think it's very empowering. It was very purposeful but not comfortable that at the beginning of this conversation I mentioned that I personally have been suicidal at a part of my life, right? My savior is sitting in the corner of that room, my father. Nonetheless, and that has to do with connections. Is it easy for me to say that? No, but I will say it because from the outside, I am someone who has everything in life. I don't have a wife anymore, but I have everything that anybody would want to desire. And so it's not something that only affects a certain kind of person or certain, no. So I think it's very empowering to be able to say that and have people hear it, and it would be empowering to them to know that if they have something to talk about, they should talk about it.
Go ahead.
Talking about subconscious and the people who have experimented severe post-trauma and or any kind of severe childhood traumas and is deeply rooted into their subconscious and is driving their life. Do you think the social prescription is enough for dealing with that kind of situation, or really and truly try to go to the next step of any kind of prescription to help them at least to ease off on their issues and try to help them out?
I think I briefly mentioned that a lot of times medication, especially for people who are in the depths of despair, are useful as a bridge anyway. But to put somebody on medication and choose to commit them to that medicine for the next, so however many decades, is probably not the right way of doing it. I think that these things have to go hand in hand. And so once you start with the medical side, but you start reconnecting this person in ways of reintroducing them to whatever semblance of normalcy you can have, you can revisit the drug side again. So, like I said, I'm not here to completely discredit all medications, but I'm here to say that in particular that class of medicines, SSRIs, have very poor data on efficacy on themselves anyway. They could be a crutch for something. That's about it. Just for the benefit of everybody else, I know you've been very patient, and this has been a long presentation, so if you allow me to, let's go ahead and break the event, enjoy some refreshments that have been put together by the community here, I'm very thankful to have been your guest today. I absolutely enjoyed the beauty of the elevation here and the mountains. I connected with nature on my way in, and I invite you to reconnect with nature on your way in. Thank you so much.